I'm going to talk about common managed mistakes. These are my financial interests, none relate to this talk. And I feel like I can talk about mistakes because I've made every one of these multiple times. I do think herpetic keratitis is a very challenging problem and one of the more difficult things that we take care of as cornea specialists. So the first mistake I want to talk about relates to what Dr. Sarnicola talked about. It is not understanding the correct clinical diagnosis. We first presented this classification in the Journal of Cornea in 1999, and we've updated our textbook, the last one coming out in 2017. But what I see often in patients referred to me is a diagnosis of HSV keratitis, which is really not a diagnosis. That's like saying a red eye. So we have to be much more specific about what is actually happening so we think we can understand the therapy. And so each one of these diagnoses should fall into a category. Is this infectious epithelial keratitis with a dendrite, infectious epithelial keratitis with a geographic ulcer? This commonly gets mistaken as because it's a dendritic shape, but it's actually neurotrophic keratopathy, as is this neurotrophic ulcer we can see here. And then finally, the immune diseases. This is immune stromal keratitis here, and this is endotheliitis. So to label each one of these cases as HSV keratitis really does not get you thinking as to what is the exact pathophysiology is what's happening. Mistake number two I see often is overuse of topical antivirals. And really, we know the treatment of debridement and the topical medications, whether it's trifluridine or ganciclovir, acyclovir, and whether you use oral antivirals or not. But topicals, it's very rare for a dendritic or geographic ulcer to persist as an infectious lesion more than 7 to 10 days. And often we see the transition into the neurotrophic change, but yet the patient's on a topical antiviral for weeks and weeks. Now, the exceptions are immunocompromised patients, and sometimes we do see resistant strains, but that's extremely rare. So if you're treating a topical lesion and it's beyond 7 to 10 days, even though it has this dendritic pattern, rethink your diagnosis. Most likely it's a neurotrophic change over the previous infectious dendrite, and we want to change our therapy and get off topicals and then do things to improve the ocular surface. So we talk about this dendritic epitheliopathy, which occurs in every dendritic ulcer. It often negative stains where the healing epithelium is, or it's an ulcer, but not a geographic ulcer. It's a neurotrophic ulcer, and there's no active virus in this lesion, and chronic topical medications will not make the patient better. Mistake number three is avoiding topical steroids for early inflammation. We often see the instruction is never use topical steroids to treat a dendritic ulcer, which I agree, or an active infectious epithelial keratitis. However, these patients go on in the next week or two to inflammation, and we see a progressive inflammatory reaction in the anterior stroma, as we can see here, and an early inflammatory reaction as the dendrite is resolving. So to withhold steroids in patients like this, even though there's been a recent infectious epithelial lesion, is allowing the patient to get scarring and loss of vision. So this patient here had one dendritic ulcer, was not treated with steroids, and then about 2 months later had 20/80 vision with a permanent scar. So again, we don't use steroids for active infectious lesions, but almost every dendritic ulcer I see that's in the visual axis, I will ultimately treat with topical steroids. So consider them for subepithelial haze, for intrastromal inflammation. Again, we avoid them for the active infectious lesion, and we avoid abrupt discontinuation. And then, of course, anytime we're on a topical steroid, we have antiviral coverage orally. Mistake number four is the underuse of oral antivirals. And I still see many patients who are treated with topical alone that go on to have lesions that will benefit from oral. So what are the indications for oral antivirals? Well, we'll talk about active infectious disease, and of course, as Dr. Sarnicola mentioned, the use in prophylaxis for a couple indications. So what infectious disease do we want to treat? Well, I think all cases of endotheliitis benefit from oral antivirals. There's active viral replication in the anterior chamber that really is at the level finally at the endothelium, giving that lesion. And so this is a linear endotheliitis with a leading edge of inflammatory cells, but there's active virus, and topical will not treat this. In patients with iridocyclitis, good studies show that we often see, or most often see, infectious lesions in the anterior chamber, and besides the topical steroids, we need to cover them with oral antivirals. And then I would urge you to consider use in many cases of infectious epithelial keratitis. I use them in all patients with dendritic and geographic ulcers. We certainly want to use them in patients who are immunocompromised because of the risk of a systemic spread. In children with keratitis or uveitis, it's extremely difficult to get topical medications in children, and we published a paper many years ago on the use of oral meds for these, and then again, plus minus on active infection. Certainly for prophylaxis, any patient who gets a keratoplasty, whether it's a dog or a penetrating keratoplasty, should be on an oral antiviral coverage for life. Certainly consider in monocular patients with recurrent HSV, it just takes one lesion in the central cornea to make this patient lose vision. So my monocular patients are on indefinite oral antiviral for protection. And then children with recurrent HSV, in one episode, besides taking the child out of school, often takes one of the parents out of work, and it's difficult to manage these children, so you want to prevent recurrences. And then if you don't use it for every infectious lesion, consider those who are having multiple recurrences, and that's the one way to stop the recurrences. Mistake number 5 is the discontinuation of topical steroids for chronic immune disease. And I often see that the clinician's goal, once steroids have been initiated, is to get the patient off the steroid, not to get rid of the inflammation. So what are the advantages of topical steroids for HSV? Well, it's the most effective way of treating corneal and intraocular inflammation. It reduces corneal scarring and neovascularization, and it reduces the complications of inflammation such as secondary glaucoma. So the most powerful tool we have to keep that cornea clear. The most common management error is that a patient presents with inflammation in the cornea and the clinician's goal is to stop the steroid. And again, I think we'd be better off if we took every patient with immune stromal keratitis and left them on steroids forever than to allow the discontinuation of steroids and the recurrence of inflammation, because what happens is each time there's recurrent stromal reaction, there's most likely permanent stromal change and gradual loss of vision. And this patient is a patient I took care of for many years. He'd come in with stromal inflammation, we'd put him on steroids, we'd tell him not to stop the steroids, he'd go back to his rural community, they'd taper the steroids, they'd get another recurrence. And after about 5 recurrences, he now has a densely scarred cornea with 360 degrees of corneal neovascularization, and this is a patient with a very, very poor prognosis for keratoplasty. So the discontinuation too soon causes loss of vision, will end up causing intraocular complications like glaucoma and cataract. So the argument against long-term steroids is that we risk, say, secondary infections, and we need to watch that if there's an epithelial defect. We worry about cataract formation, but again, I can manage a cataract in an HSV patient much better than a corneal scar. And then this induction of what we call, at least some clinicians call, the dependency on steroids, or a steroid-dependent cornea. I think the inflammation dictates how much steroid and how long, not that once you start a steroid, the patient's committed to a steroid. And we have this balance of, is our goal to prevent corneal scarring, or are we trying to avoid cataract, glaucoma, and steroid dependence? And I will tell you this, if we don't use enough steroids and we end up with a corneal scar, this patient will get a cataract, most likely will have glaucoma, and will end up being steroid for life because this patient will need a keratoplasty for visual recovery. So again, I can deal with a cataract, I can deal with increased intraocular pressure. The worst thing that we can let happen in a patient with chronic immune stromal keratitis is to undertreat it and allow a corneal scar. So we look for the flare dose. All these corneas have kind of breakthrough inflammation, and if we are using prednisolone or other steroids and we go from 6 times to 4 times to 3 times, and they break through when you go from 3 to 2, there's no reason to take that patient down to twice a day for many, many months, if not for longer, because they will flare again. So we always kind of document a flare dose, and we stay above that dose for many, many months, if not forever. And then finally, mistake number 6, undertreatment of neurotrophic keratopathy. And what happens is we don't need a full-blown neurotrophic ulcer to cause loss of vision. If we have an abnormal epithelium from neurotrophic disease, and we don't address the abnormal epithelium, ultimately we're going to get progressive subepithelial scar and loss of vision. And so I would advocate aggressive treatment. If the epithelium isn't healthy, if there's fluorescein staining to any degree, you need to do something else to make the surface better, whether we're talking about stopping toxic meds, punctal occlusion, long-term bandage contact lens, amniotic membrane transplant, topical growth factor, or tarsorrhaphy. If there is persistent epithelial disease, you need to be more aggressive about treating that. So in summary, I'll flip it the other way and talk about the pearls that I could give you in managing HSV that I've learned over 35 years is understanding and label the correct presentation and be very specific, show restraint in the use of long-term topical antivirals, do not fear topical steroids even if it's immediately after that infectious epithelial lesion, whether it's a dendrite or a geographic ulcer. Almost all those corneas have inflammation. We'll get some scarring. Oral antivirals are the safest long-term thing you can do for patients. Have confidence in using long-term steroids, and you're better off overusing steroids than underusing steroids. And then finally, aggressively treat neurotrophic keratopathy. Thank you.
Thank you, Drs. Holland and